Dear Dr. Bernstein and Aya, this is my interprofessional presentation on pain management. This is for Community Geriatrics. I'm Christian Fernandez Falcon, the Vice Chair of Geriatric Services. The objectives of this presentation is to be able to define pain, to be aware of the prevalence of pain in different settings, to classify pain, to understand how to assess pain, to understand how to treat pain, and finally, for the interprofessional piece, to understand how interprofessional collaboration improves pain outcomes in older adults. The definition of pain is an unpleasant experience that is sensory and emotional, that is associated with actual or potential tissue damage, and that is described in terms of that damage. The prevalence is on adults 7 to 80 years old, 30%, so 1/3 of the population. But when we are talking about adults more than 85 years old, it's 80%. For community dwelling, more than 65 years old is 25 to 50%. But when we're talking about nursing home residents, this escalates to 45 to 80%. The interprofessional piece of the care and management of pain is that effective management of pain in these different settings requires contribution from multiple disciplines consistent with interprofessional care models. And it also requires team-based assessment and communication. When we're talking about the classification of pain, we're going to talk about type. There are 3 types: nociceptive, neuropathic, and nociplastic. Nociceptive pain is pain that arises from actual or threatened damage to non-neural tissue and is due to the activation of nociceptors. This is by Bonessi et al. In 2020. Neuropathic pain is a maladaptive response triggered by lesions to the somatosensory nervous system that alter its structure and functions so that pain occurs spontaneously. Finally, nociplastic pain is that which arises from altered nociception despite no clear evidence of actual or threatened tissue damage, or evidence for disease or lesion of the somatosensory system. This is by Cooker et al. In 2023. When we refer to the duration of pain to classify it, we have acute pain, which is the sudden onset of pain which signals actual or threatened tissue injury, often resolves within days to months, and usually declines as the underlying cause heals. This is by Raja et al. In 2020. Chronic pain is that pain that persists or recurs beyond the normal healing time, typically defined as beyond 3 months, and may become the primary clinical problem rather than simply a symptom of underlying tissue damage. This is by Nichols et al. In 2019. The assessment of the cognitive adaptation is done by history mainly, and this is obtained by using the acronym Likert AAA, which we see in the screen. For the assessment of the cognitive adaptation, the recommended 10-minute battery comprehensive assessment of pain for older adults is a combination of the brief pain inventory and the short-form McGill Pain Questionnaire 2. Here is where the interprofessional piece is important. The interprofessional implementation of standardized assessments improve care consistency, and the shared documentation of pain throughout different professions enhances communication across the care team. When referring to the brief pain inventory, one of the main advantages of it is that it differentiates everyday pain, which we all suffer from, and it's a normal component of our lives, from pain, establishing expectations for pain control. Allows for the differentiation of 16 different pain qualities, gives quantitative values from 1 to 10 to the level of interference over the functions of the patient over the last 24 hours, and it refers to general activity, mood, walking, work, relationships, sleep, and enjoyment of life in general. This is administered by professions other than physicians, which typically are nurses or physical therapists. As you see here on the screen, this is the instrument. The second part of the recommended battery of tests is the short form McGill Pain Questionnaire 2. It allows for the differentiation between 22 types of pain and gives quantitative values. And on the screen we see how the tool looks. Again, this is administered by professions other than physicians, typically nurses and physical therapists. For the interprofessional pain assessment, physicians and Ps and PAs typically do the medical evaluation, diagnosis, and treatment planning. The nurses will participate most often on ongoing assessment, monitoring, and communication during transitions of care. The pharmacist typically will do medication reconciliations, look into interactions, look into deep prescribing, and typically do most of the opioid stewardship. PTOT will look into function and typically mobility, and will try to attempt functional restoration and adaptive strategies. The behavioral health professionals will contribute with CBT, with coping strategies, and with mood assessments. And social workers will contribute and hasten accesses to resources, to caregiver support, and exploring the social determinants of health. Interprofessional roles reinforce complementary expertise and improve quality of care. For the treatment, there is pharmacologic therapy and non-pharmacologic therapy. For the pharmacologic therapy, there are simple analgesics, opioid analgesics, and adjuvant analgesics. And for the non-pharmacologic therapy, there are psychological interventions, physical interventions. But for the interprofessional piece, the professional integration of these modalities have shown to improve functional outcomes. The pharmacological treatment, the simple analgesics are acetaminophen, NSAIDs, and COX-2 inhibitors. The pharmacologic treatment is opioid analgesics, typically WIC, which are most often used and have less restrictions, or tramadol, tapentadol, and buprenorphine. For the pharmacologic treatment, again, opioid analgesics, this time strong analgesics are morphine or similars, being that codeine, hydromorphone, oxycodone, and fentanyl in progression. For the non-pharmacologic treatments, which are the most often used by professions other than physicians, are the psychological interventions and the physical interventions. The psychological interventions, typically the behavioral health professionals, the physical interventions, typically PT and OT. And for the interprofessional care, why? It enhances accuracy of pain assessments, it supports functional goals, it addresses psychological drivers of pain, and it supports in general safety culture because of the need for communication between the different interprofessional components of the team. It improves communication across care transitions, reducing fragmentation of care, and improves coordination of care across disciplines, improving outcomes and diminishing costs. Different professions working collaboratively rather than in parallel with less task duplication. So what are the conclusions? Pain is highly prevalent in older adults. Standardized assessments support shared understanding and communication. Interprofessional approaches improve diagnostic precision and treatment quality. Pharmacologic and non-pharmacologic treatments are most effective when coordinated across professions. And functional improvement, not pain elimination, is a central goal of geriatric pain management. Thank you for your time and attention. And these are my references for the presentation in general. And these are my references for Module 8 for the interprofessional education piece.